Hi everybody. Today we are going to learn about ARDS. What is ARDS? It is Acute Respiratory Distress Syndrome. What happens in ARDS? It's a respiratory failure. It's due to damage to the alveolar capillary membrane that leads to accumulation of fluid in the alveoli. In this picture, you can see an alveolar sac. It is covered by the alveolar capillary membrane, and when there is a damage to the alveolar capillary membrane, protein-rich fluid accumulates in the alveoli. That leads to respiratory failure, that is ARDS. You can see a normal, healthy alveoli or alveoli sac surrounded by the capillary membrane, whereas in ARDS, you can see damage to the capillary membrane. As a result, fluid accumulates in the alveoli. If you look into the anatomy, so you know air enters the upper respiratory tract, enters the lower trachea, divides into bronchi, and each bronchus enters the lung. And in the lungs, bronchi further divides into secondary, tertiary bronchi, finally into bronchioles, and end up in alveoli sac. This is the end point of respiration. This alveoli sac has cluster of alveoli. You can see alveoli sacs, and each alveoli sac has cluster of alveoli. And the function of the alveoli is gas exchange. What is gas exchange? So the alveoli sac is surrounded by capillaries, and the alveoli provides oxygen to the blood, and carbon dioxide from the blood passes through the alveoli and it is exhaled through the respiratory system. This is known as gas exchange. So the alveoli helps in gas exchange. Now let's see what are the types of alveolar cells. There are three types of alveolar cell. First is type 1 pneumocyte or type 1 alveolar cell, type 2 alveolar cell or type 2 pneumocyte, and third is alveolar macrophages. What is the function of type 1? The type 1 alveolar cell, it helps in gas exchange. Now the type 2 alveolar cell helps to produce surfactant. What is surfactant? So when the air is exhaled out through the respiratory system, and the surfactant which is produced by the alveolar cells, it prevents alveoli from collapse. It decreases the surface tension and keeps the lung alveoli open. It prevents lung collapse. That's the function of the surfactant, and it is produced by the type 2 alveolar cell. Third is alveolar macrophages or alveolar macrophages. Alveolar macrophages helps in the immune system. When a foreign substance or foreign particle is inhaled into the alveoli, these macrophages ingest this foreign substance or foreign particle and helps in the immunity. So these are the three types of alveolar cells. Now let's see the causes. What causes ARDS? ARDS is caused by either direct injury to the lung or indirect injury to the lung. What are the direct lung injury? Pneumonia, that is infection of the lung alveoli, aspiration, gastric aspiration. When gastric content is aspirated to lungs, it is highly acidic in nature that can damage the lung. Lung injury, lung contusion, fat emboli, drowning, inhalation or reperfusion injury. All this lung injury can lead to ARDS. Now what are the indirect lung injuries? Sepsis, that is systemic inflammatory response to an infection. Sepsis, multiple trauma, bypass surgery, drug overdose, pancreatitis, and multiple blood transfusion. It all can trigger an inflammatory response. When there is a systemic inflammatory response, it damages the alveolar capillary membrane that can lead to ARDS. Now let's see the phases or the stages of ARDS. ARDS has three stages or three phases. The first is Exudative Phase, second is Proliferative Phase, and third is Fibrotic Phase. Now let's look into Exudative Phase. What is exudative phase? It happens acutely within 24 to 48 hours after injury. As you know, in ARDS, there is a damage to the alveolar capillary membrane. So when there is a damage to the membrane, fluid leaks into the alveoli. When fluid leaks into alveoli, that leads to pulmonary edema, and there is damage to the alveolar cells which produce surfactant. There is no surfactant, that leads to atelectasis or lung collapse and formation of hyaline membrane. What is hyaline membrane? Hyaline membrane, as you know, in this phase, there is damage to the alveolar cells, and the damaged alveolar cells accumulate in the alveoli, lead to the development of hyaline membrane. All these three can lead to impaired gas exchange. Gas exchange won't take place in alveoli, leads to refractory hypoxemia. That means you may be providing the patient with high amount of oxygen, high FiO2, but patients may still remain hypoxic. So in exudative phase, pulmonary edema happens, atelectasis, development of or formation of hyaline membrane that leads to impaired gas exchange. And all these can lead to refractory hypoxemia. That means patient may remain hypoxic even after providing high concentration of oxygen. Following the exudative phase, the next is proliferative phase. This stage or this phase develops 14 days after injury. That means after injury, body is trying to repair or regenerate the alveolar cells, and some of the lung tissue may get dense and fibrous. As a result, pulmonary hypertension can occur and pulmonary vascular resistance may occur. Some of the patient may recover during proliferative phase, but if not recovered, this patient may progress to final phase, which is called fibrotic phase. What is fibrotic phase? It's the third stage of ARDS. It happens or occurs 3 weeks after injury. And during this stage, there's a major fibrosis of the lung tissue, major fibrosis. And in those patients, the prognosis is very poor or there is poor recovery. So we learned about the 3 phases of ARDS. Exudative, the initial phase. Proliferative, trying to proliferate, regenerate the alveolar cells. Some patient may recover during proliferative phase. If not, leads to fibrotic phase, which is major fibrosis of the lung, which patients may have poor prognosis or poor recovery. Now let's see the signs and symptoms. It's a respiratory failure. The patient may have difficulty in breathing, shortness of breath, heart rate may increases due to hypoxia cyanosis. Pulmonary edema can lead to frothy sputum, acidotic nature, pH, abnormal breath sounds, crackles. Initial phase, due to tachypnea, PaCO2 drops, but as the condition worsens, PaCO2 increases, leading to respiratory acidosis. PaO2 decreases, hypoxemia, which is refractory. That's a classic sign of ARDS. That means patient may require high amount of FiO2, high oxygen concentration, but still remain hypoxic. How can you diagnose ARDS? There is no specific test for ARDS, but in the ABG, you may see refractory hypoxemia. Chest X-ray show diffuse pulmonary infiltrates. Pulmonary capillary or artery wedge pressure if less than 18 mmHg. That means there is no evidence of heart failure, because pulmonary edema can secondary to heart failure. If the pulmonary capillary wedge pressure is less than 18 or normal, that indicates the pulmonary edema is not secondary to heart failure, and ARDS is acute in onset. This is the image of a patient with ARDS, and you can see all white patches, diffuse bilateral infiltrates. Infiltrates both lungs. So remember the key points. It is acute in onset. Within 48 hours after injury, X-ray shows bilateral diffuse infiltrates, severe hypoxemia, non-cardiogenic pulmonary edema, which is pulmonary capillary wedge pressure less than 18. So what is PF ratio? PF ratio means PaO2 by FiO2 ratio. What is PaO2? It's the partial pressure of oxygen in the blood divided by fraction of oxygen delivered. So it's a understanding that the patient oxygenation with respect to the oxygen delivered. PaO2 you can assess by doing a patient's ABG, whereas FiO2 is the amount of oxygen delivered to the patient. Now let's see an example. This is the patient 1. The patient is on room air and ABG shows PaO2 of 60. To calculate PF ratio, PaO2 is 60 and FiO2. Remember, the room air has 21% of oxygen. So 21% means 21 divided by 100, that is 0.21. So PF ratio is 60 divided by 0.21. It is 285. So the PF ratio of patient 1 is 285. Now let's look at the patient 2. The patient is on mechanical ventilation and ABG shows PaO2 of 90. Patient is receiving 50% of oxygen, FiO2 of 50 through mechanical ventilation. So the PF ratio is 90 divided by 0.5. 0.5 means 50 divided by 100, 0.5. 90 divided by 0.5, that gives 180. So the PF ratio is 180 in second patient. So remember, if PF ratio is less than 300, the normal should be always greater than 300. But if it is less than 300, there is lung injury, acute lung injury. And if PF ratio is less than 200, that indicates the patient is developing acute respiratory distress syndrome. Now let's see the management of ARDS. The patient with ARDS are hospitalized and treated in ICU, and these patients may require oxygen and usually mechanical ventilation with high PEEP. Also, these patients are positioned in prone positions. What is PEEP? PEEP is positive end expiratory pressure. That is, the pressure in the alveoli at the end of expiration. This helps to keep the alveoli open. Remember, in ARDS, alveolar cells are damaged. There is no surfactant. Alveoli may collapse. So to keep this alveoli open, high PEEP is provided. Usually it's kept at 5 to 10, but in patient with ARDS may require PEEP greater than 10 or greater than 12. But the side effects include you are providing high pressure to the alveoli. As a result, trauma, paratrauma to the alveoli. And when you provide high pressure to the alveoli, the intrathoracic, the pressure in the thoracic cavity increases. So when the pressure increases, the venous return, the blood supply to the heart decreases because there is high pressure in the thoracic cavity. As a result, cardiac output decreases. And when there is a decreased cardiac output, blood pressure may drop, patient may get hypertensive. How do patients get benefit with prone position? In prone position, patient is laid on their stomach. So it helps to improve oxygenation by improving the perfusion, blood supply and ventilation to the lungs. It also helps in the drainage of the secretions. If the previous measures fail, another option is ECMO, that is extracorporeal membrane oxygenation. That is, blood is taken from patient's body, pumped to the ECMO machine where oxygenation takes place and pumped back to the heart. Another treatment option is inhaled nitric oxide. Inhaled nitric oxide is a vasodilator, so it improves oxygenation by increasing blood flow to the lungs. It also, other management includes identify the cause. Remember, it's a systemic cause or there is an underlying injury. So treat the underlying cause. If it is infection, treat with antibiotics, corticosteroids, which has anti-inflammatory properties. Adequate nutrition, it is given enterally. Also, VT prophylaxis and prophylaxis to prevent GI bleeding. So the key point in ARDS, it's a severe systemic condition and you have to treat the whole illness. So today we learned about ARDS and thanks for watching my video.